My name is Jim Torey. I'm the director of the IVUS Core Lab at St. John Hospital and Medical Center in Detroit, Michigan. And it's my pleasure to present the Sync case study. A brief history of the patient. The patient is a 73-year-old white male who is being admitted with an acute anterior wall MI. The patient has a past medical history significant for non-insulin-dependent diabetes mellitus, hypertension, dyslipidemia, and a remote history of CVA. Pre-catheterization history, the patient states that he has a history of having a stent. He is unsure of where the stent was placed, but it was placed approximately a year ago at an outside institution. We have no access to films at the time. The initial angiograms are seen here. This is the RCA. In multiple views, we see no collaterals going to the left anterior descending territory. Here's the left coronary artery, and the first thing we notice is this patient has extensive tortuosity in the left coronary system and a total occlusion of the left anterior descending artery. After wiring the vessel, we immediately got back flow, but we saw a large thrombus burden, and we followed that up with thrombectomy and a quick PTCA. After PTCA, we decided to do an intravascular ultrasound. This is the platinum catheter marketed by Volcano, and you can see the fairly characteristic markers on the device. So here's the intravascular ultrasound of the LAD, and you can see the stent in the mid-LAD, and as we cross into the septal perforator, you can actually see some gross malapposition extending proximal to the S1, and then a large thrombus sitting in the proximal LAD, in that lesion basically extending up to the ostial LAD. So what would you do now? Would you stent the LAD? Would you treat this patient medically? Cabbage consult. You can think about possibly IABP insertion because of the large thrombus burden. A lot of different options here for us. Where I think most people would agree is that we would stent the LAD. But there's, of course, challenges in stenting this LAD. First off, what length stent would you use? We've already done an IVUS, but that doesn't precisely measure the stent length. What size stent would we use? Well, IVUS actually can help us here, but what angle would you land it in? We've tried multiple projections to bring out the ostium of the LAD, but because of the tortuosity, we actually were having very little luck. So we have to precisely place a stent inside a malapposed stent and land it precisely at the ostium that we cannot visualize angiographically. So there are some distinct difficulties with this case. So the first thing we did was we started using the last few months, about the last 6 months, we've been using the Sync system. This is also marketed by Volcano, and with this we can actually sync the angiogram to the intravascular ultrasound image. It does require a rather meticulous pullback, manual pullback though, which is nice, but you have to be fairly methodical. But the benefit is that you can actually get lengths in these patients which are fairly accurate. They're not exact, but they're very close. So the first thing we did was we measured the length of the previous stent, and you can see here the stop and start of the distal stent, and it measured out at 32 millimeters in length, and the distal stent measured out at 3 millimeters in diameter. This is the S1 bifurcation, which you can see here, and this is a nice look at how well the co-registration went for this patient in particular. You can see the large S1 in the IVUS image coming off at 9 o'clock, and how it correlates with the angiographic image, where you can see the yellow marker showing that it's sitting directly on top of the S1 at that point. So this is a very nice co-registration. Here, where we see the large lucency on the angiogram, it also shows a nice co-register with IVUS. You can actually see a fairly large thrombus burden sitting at 7 to 8 o'clock, and a small septal perforator located at 3 o'clock. So very, very nice image as well. On the distal end, the first thing we had to figure out is how big of a stent we needed to put in to land it distally so we can actually fix the apposition problem on the distal end. The stent, again, is 3.1 in size, but the lumen at this point was 5.1. So we had at its largest point. So that's substantially more than what the stent could probably provide on its own. On the proximal end, we see the vessel becoming a bit smaller. So we are going to use this, since this is our smallest reference, to actually size the stent. So not only do we look at the proximal target, but we're also looking at sizing for how big of a stent we could possibly squeeze in. Also notice though on the angiogram that it's hiding at this point behind the circumflex. When we size a stent, basically there are several different ways you can do it. You can actually use 80% of the average reference diameter, but what we use at our hospital is a simple midwall measurement. This is going into the smallest reference, which is usually the distal reference, and making two diameter measurements. The EM, which case in the proximal here is 5.1, and the lumen, which is 3.5. So we average the two, the lumen and the EM, and that's what gives us the midwall. What's kind of convenient about the sync system is actually when you make these two diameter measurements, it actually gives you the average. So midwalls couldn't be easier than using the sync system. So considering that the distal reference we needed close to 5, and the proximal end we could midwall it out to 4.3, we opted for a 4.5 millimeter diameter stent. As far as the length, this was going to be another challenge. We had to actually overlap into the existing stent, but at the same time we had very limited choices when it comes to a 4.5 stent. So we measured it out, and from the ostium, which you can actually see here on the IVUS image with the circ coming in at 3 o'clock, from that point back to where we want to land inside the stent, which is immediately proximal to that large S1, measured out at 12.9 millimeters in length. If you look at from distal to proximal, proximal to distal, they both measure out at roughly 13 millimeters in length, and these would be the two areas that we would be landing our stent in. So this is actually two very nice landing zones. This is the problem though when we're talking about trying to line up these stents on the angiogram, is that no matter what caudal angle we tried, we could not fully pull that LAD straight off the circumflex so we could get a clear look at it. And this is basically the problem when you're dealing with ambiguous angiograms. Anytime you have excessive angiographic views, not only are you boosting the radiation to the patient and increasing dye use, but you're also doing it to yourself. Interventional cardiologists typically take much more radiation than even radiologists do. And it's something to be aware of. The less angles we use, the less fluoro we use, the less dye we use, the better. And the Mozart study, which recently came out in 2014, showed that if you really stuck with IVUS guidance, it resulted in substantially less contrast, which is a good thing. So here we are trying to line this thing up, and now we're using another part of this thing called device detection. And what this does is it actually tags the two little black dots of your stent proximally and distally, and then when you try to line it up, you'll see in the bottom corner it shows the shifting between systole and diastole by putting in little yellow dots. So when we first did a dye injection, a contrast injection under fluoro, we went ahead and looked at it, and we saw that this is just a bit too distal. You can see that on the distal marker is just a little too close to the S1. The nice thing about this is that we did this without cine. This will actually take fluoro and actually create these images based just on fluoro. Here's where the stent is actually lined up very nicely. This is basically exactly where we wanted it to be based on the initial analysis. So when you actually compare what we looked at and how we measured out from ostial to the proximal LAD, just proximal to that large S1, you can see that this lines up precisely with where we wanted to land. So with that in mind, and this is a synopsis here showing how everything lines up pretty much precisely. So we went ahead and deployed the stent where we thought it was appropriate, and we did this based purely by what we saw on IVUS. And again, by fluoro, the device detection will actually show the stent deployment without the use of cine. Both of these were actually stored using live fluoro, and they will actually show up as something you can use later on. Afterwards, now again, this is a post 4.5 by 13 bare metal stent. You can actually see this is the distal stent, which of course is okay, but then we overlap into the proximal stent here, and you can see a very, very large result, much better apposition, and a very large lumen gained in the proximal LAD. And here it will actually go into the circumflex, which is going to be coming in around 3 o'clock right here, and into the left main, which clears out of any stent struts. So that's a very nice stent placement. Here's some sample slides, and you can see the ostial LAD is clearly covered, and in the very distal left main we see the stent struts dissipate, and basically we have a nice clean landing just barely into the left main. So this is a fairly precise landing despite the fact that we had major limitations. A few words about ostial lesions. These are very challenging lesions to treat, and we actually seen with intravascular ultrasound significant benefit from using intravascular ultrasound alone. Patel did a study very recently in 2013 that showed a 50% reduction in the composite of cardiovascular death, MI or TLR, a 61% reduction in MI, trend towards lower TLR. So it's definitely worthwhile going after these ostial lesions with IVUS guidance, and I think it's especially helpful using this sync system. So in conclusion, IVUS provided significant information regarding the pathogenesis of this acute event. It did provide very, very helpful information, but we still had a lot of unanswered questions as to how to actually treat this vessel. Angiography itself was very limited in helping in this regard, so we just couldn't use the angiographic information to land this stent. This is where the sync came in. The sync basically takes the strengths of both technologies and kind of creates a nice synergy. And it does show promise in providing useful guidance in very challenging interventions. What I think was especially interesting is, despite the complexity of this case, from the time we did the initial IVUS to the time we went post-stent, the whole procedure took 20 minutes from IVUS to IVUS. And that actually is not a long time to do something this complex and get this nice of a result. So overall, we're very pleased with what we've seen so far. And with that, I'd like to thank you for your time, and have a good day.